name is Dr. Juli Owens, and I am one of the staff doctors here at Georgia Chiropractic Neurology Center. Today's topic that we're going to discuss is understanding dysautonomia and the functional neurological approaches that we use to assess and treat it. So maybe you're hearing some of these terms for the first time, or you're a patient and you're sending this video to friends or family to try to understand a little bit about what you have going on. So for that population, I'm going to try to make this talk a little bit digestible. But also, I just want to say that at GCNC, we have a big respect for the fact that many of our patients have been dealing with these disorders for a really long time and have become almost an expert in understanding what their disorder is and what the types of things that are involved in it, just simply by the nature of needing to advocate for themselves often. So hopefully I can give both of those populations of people a little bit of good information to take away from this today. So we're going to start by talking about the autonomic nervous system because that's the system that is affected in dysautonomia. When you hear autonomic, you should think automatic. So it's things that your body should do without you having to tell it to do it. So it's the part of the nervous system that regulates functions that are automatic in nature, such as heart rate, blood pressure, digestion, excretion, perspiration, temperature regulation. So everything that your body does that you shouldn't have to consciously think about. The way people are most familiar with this system is when it's talked about in the two different divisions, and that is the parasympathetic or rest and digest nervous system and the sympathetic nervous system, which is your fight or flight system. So this is just a basic diagram that I like that shows the two different divisions and some different things that they do in the body. Things like pupillary constriction and dilation, salivation, stimulating and inhibiting that, airway constriction and dilation, digestion, different processes with different organ systems, even the reproductive system and your bladder, how it's constricting and relaxing. But one of the things I wanted to point out here was the fact that you can have both sides of the spectrum in a lot of different physiological functions that are affected. So you can either have a decrease in heart rate or an increase in heart rate. You can have constricted pupils versus dilated pupils, and those have a range of different symptomatology that are also associated. So because there's so many different organ systems and processes in the body that are affected by the nervous system, you can get a very broad array of symptoms and disorders. So what is dysautonomia? Well, the simplest definition is just a dysfunction of the autonomic nervous system. So when there's dysfunction or failure of the autonomic nervous system, the result is a disorder classified as a type of dysautonomia. So I want to make this part clear is that dysautonomia is not in and of itself a diagnosis. It is an umbrella term for a whole host of disorders that affect the autonomic nervous system. So some common symptoms that we see are dizziness or fainting. This can also be things like pre-syncope, where you feel like you're going to pass out, but you don't actually pass out. Fatigue, brain fog, rapid heart rate. It can be slowed heart rate, palpitations, GI issues, temperature intolerances. And then one of the big things is anxiety-like sensations that don't have an emotional cause or trigger. One of the reasons I say big is because a lot of people with dysautonomias, especially POTS in particular, they take a while to get diagnosed. And so POTS on average takes, in research, around 7 different physicians and 4 to 6 years. And there is a gender bias towards that, where women tend to take longer to get diagnosed with POTS or dysautonomia. And that's simply because a lot of times they first look at the anxiety-like symptoms and try to treat those and don't realize that it's an underlying dysautonomia. So 75% of POTS patients are initially misdiagnosed. So I just want to make it very clear that these are neurological symptoms. They're not simply psychological. And these symptoms can be transient and vary in severity from day to day. And so that's one of the things that makes it hard sometimes to get a diagnosis, is the fact that one day maybe you're a mom and you wake up and you feed the kids and you get them off to school and you clean the entire house and you do the laundry and you do all the things that you want to do in a day plus some. And then the next day you can hardly get out of bed. And so there's a variability to what's happening with you on a day-to-day basis that sometimes makes it hard for people to understand that these things are still happening physiologically in your body. I took this little quote from the Dysautonomia Project, and it says, "This is not an exhaustive list of symptoms, Any symptom in any organ system could potentially be the result of an autonomic disorder. Understanding which symptoms affect you the most is important when identifying treatments with your doctor. And so that'll be a little bit more important later when we look at the fact that there's so many different subtypes and so many different regions in the body that are affected by dysautonomias. So this is another picture that I liked and pulled up because it just shows all the different areas in the body that can be affected, which is really realistically globally. So you can have impaired pupil responses. So sometimes that means your pupils are too big and they allow too much light in. So you can get things like light sensitivities. People have migraines, they have cognitive deficits, brain fog, fatigue, difficulty sweating and tearing. They can also have an overproduction of sweat. So a lot of people have clammy hands, shortness of breath. They can be easily winded. They can have exercise intolerances. It also has a lot of times we see people with dysautonomias having gastrointestinal issues. So they might have constipation or diarrhea, pain in their abdomen, reflux, heartburn. You have urinary issues with either excreting too much or too often or retaining too much. You can get cardiovascular feelings with palpitations, chest discomfort, high or low heart rate, high or low blood pressure, and then blood pooling, which is that heavy feeling that people get in their legs. What causes that heavy feeling people get in their legs that is often associated with POTS or dysautonomia. So I have quite a few slides on the different types of dysautonomias. We're only going to go over some of them, but if you feel the need at any point to pause this and look at the different things that can be affected and know somebody with that diagnosis or have that diagnosis and want to reach out, feel free. But one of the big things we see is postural orthostatic tachycardic syndrome, or POTS. It has become a very popular diagnosis since COVID. We were treating it well before COVID, and there are other viral things that can cause it. But that's one thing that we're seeing a lot more commonly in the office. We also see things like vasovagal syncopes, orthostatic hypotensions. Also, some of these things can be degenerative, idiopathic, or genetic. So these are primary autonomic disorders, things like pure autonomic failure. And sometimes you can get familial dysautonomias. So regardless of the reasoning behind why you got it, or if it's something that's autoimmune and you need to see other practitioners to have specific medications that you're on for that, we still do a really good job of training your autonomic nervous system to work more appropriately. We have patients that are on medications, they're on beta blockers, they're on immune suppressants that see a lot of really good outcome. We also have patients that are trying to do it without, or have the ability to do it without the medications. And so we work with people and their treating doctors to be a part of their team and essentially try to get them to a point where their autonomic nervous system works well enough that they don't necessarily always need to be on a medication. And they go back to their prescribing doctor and they try to titrate off things like that if it's something that's appropriate for the case. So these are some more of the types of dysautonomia. We have secondary autonomic neuropathies. So that's just another term for dysautonomia, essentially. But infectious or post-infectious and viral or post-viral dysautonomias are very, very common. That's like the POTS we were just talking about. We see that often secondary to some form of infection or viral disorder. Head injuries, concussions, TBIs, those types of things can also cause secondary POTS or dysautonomia. We also see metabolic issues can cause it, autoimmune issues can cause it, so SLE, celiac, Sjögren's. You also have toxic or iatrogenic dysautonomias, so that's things like consuming too much alcohol or having chemotherapy, anesthesias, different medications that affect your autonomic system, and then they never quite, your autonomic system never quite rebounds out of that quite the way that you would want it to. And then I just posted these because, again, there are a bunch of different ways that you can have dysautonomias. Again, that GI disorders and gastroparesis or dysmotility being one of the issues. And then I highlighted pain and autonomic overlap because I see a lot of chronic pain patients personally. It says CRPS or complex regional pain disorder, but in reality, any form of chronic pain tends to have an autonomic feature to that disorder that can sometimes make it a little bit harder to get better. And it's typically something we start addressing first, because getting blood flow to the areas and the correct oxygen to the area and pulling the correct waste out of the area with the circulation is really, really important in chronic pain patients to be able to get them better. So my last few things about our different types of dysautonomia are things like spinal cord injuries that can cause dysautonomic symptoms. You also have brainstem or hypothalamic lesions, so things like tumors, demyelination issues, and then definitely strokes. A lot of our stroke patients that we see tend to have some form of autonomic dysfunction. It tends to go hand in hand. Now, I highlighted here hypermobility spectrum disorders, or Ehlers-Danlos syndrome, EDS. EDS and POTS, you don't have to have one to have the other, but they tend to be very, very closely associated, especially with Ehlers-Danlos being a connective tissue disorder, so a lot of those blood vessels are affected, so then you'll get orthostatic intolerances where when you stand up, your blood flow doesn't quite go the way that it's supposed to, and then you'll get dysautonomic symptoms. I also highlighted here pregnancy and postpartum. So at different times throughout your pregnancy and after you actually deliver the baby, you can have different problems with how the blood's flowing through your body. So there's different issues with fluid dynamics. And then we know there's so many hormonal changes and all the different things that happen during pregnancy within your body. It can cause dysfunction of your autonomic nervous system. So some of the root causes and triggers, things like chronic stress. We talked about infections, and then trauma and concussions. A lot of people get dysautonomia as secondary to head injuries. So we see that very commonly in our concussion patients here. We did already talk about things being post-viral. So viruses affect your autonomic nervous system pretty much always, but when you have a lasting effect after those viruses have been cleared up or the infection has gone away, then you tend to have, people can get lasting dysautonomic symptoms. Autoimmune disorders or metabolic issues, poor sleep, deconditioning, and nutritional deficits. So these are, again, just things that take a toll on your body's overall physiological function. And then I just want to stress here that the functional neurological approach to this is not necessarily identifying what the cause was, because oftentimes we do have issues that are idiopathic. So we don't always have to know this exact thing caused you to have these symptoms or for your body to function this way. But what we do try to figure out is to identify where the imbalance is coming from or originating in your body. So that leads us to talking about some of the brain regions and body regions that are involved in dysautonomias. One of the big centers we look at is your brainstem, because it does a lot with autonomic control. So we test that with looking at things like soft palate heights, with looking at tongue strengths, pupillary responses. We also check your cerebellum and see how well it does coordination of your autonomic and motor responses, but we check to see how well it's controlling how you move, your balance. Your insular cortex is an area that tells your brain about the awareness of your internal state. So it tells it about, it's the part of your brain that has an understanding of different organ functions. So that's part of the reason we also do visceral manipulation for vagal nerve stimulation as well. But one of the things that it does is it affects that enteric nervous system to give your brain an understanding of where you are in space based on what it's feeling happening in your body. We also do frontal lobe therapies. That's a big driver of cognition. That's a big driver of motivation. But it's also a top-down inhibitory control of your sympathetic nervous system. So then some of the other areas that are involved are places like your hypothalamus. It sends messages to all different types of places in your brain, limbic and cortical networks. So one of the big things is your limbic center in your brain is involved, and that is actually essentially your emotional centers in your brain. So most people are familiar with the hot button topic or term amygdala responses. And so that's part of that network that we're looking at. And then you have that interoception on there as well, talking about your body's own understanding of your visceral organs and where they are in space and how they're functioning. These brainstem nuclei are not necessarily specific things that you need to know, but they're just areas that we're aware of and looking at and testing to see is this area and involved in your specific case? So other areas in your body that can be affected are things like your autonomic sensory receptors, and so that's things like your baroreceptors, and those are pressure sensors in your vascular systems that can tell your body about how you're moving blood around and where it needs to send more blood and where it needs to decrease how much blood it's sending. Things like chemoreceptors, cardiopulmonary stretch, and then you have spinal cord and preganglionic neurons, so things like your sacral parasympathetic nuclei that help with pelvic organ control, and descending pathways from your hypothalamus and your brainstem down to those through that spinal column. And then I'm not going to go over all these different ones, but you can also have issues in those effector organs. So you can have, as we've talked about, all these different systems that can be affected: the cardiovascularly, sweat glands, pupil and eyelid muscles, GI tract, genitourinary, exocrine, and endocrine. So the big question is, how do we assess dysautonomia? And in our clinic, we begin with a really comprehensive 3-hour examination. And so during that time, we start with bilateral, so that just means both sides, seated, lying, and standing vitals. So that means that we're taking your blood pressure from side to side to see if there's a difference there. Hopefully there's not, but we're checking your blood pressure, we're checking your heart rate, we're checking your oxygen saturation, and we're seeing how your body handles gravity with a positional change. So is your heart rate increasing as you stand up and then regulating correctly, or is it decreasing when you lie down? Is your blood pressure going up in the appropriate manner, and is it doing it on both sides of your body? Those things are really important in dysautonomias. They're important for all of our patients, but we check basic autonomic functions there and are really focusing on that. We also do something called a video oculography exam. And so the VOG or VNG, video nystagmography, some people call it, it's a tool used in a lot of different types of offices. We use it to essentially assess for what your eye movements are doing in association to what it means and what the aberrancies, if there are any, mean to your brain function, so that we can more correctly pinpoint areas of your brain that need a little bit of help. Other professions might use that to check for really scary things like tumors or brain bleeds, but we use it to see how optimally we can make you function. Neurocognitive testing is another thing we do. We definitely do balance testing. We also, depending upon the person and if it seemed appropriate in dysautonomic cases, it usually is, we do a tilt table or a positional vestibular testing. So tilt table testing is something that people often wait to get into, see a cardiologist or a specialist, a POTS specialist for a really long time. It's something that we assess in our office. We use it diagnostically, but then we most definitely use it therapeutically. The other thing that we can do if we feel the need is postural vestibular testing. So that looks like putting the video oculography goggles on you and placing you in your head in different positions on a table to see what the integrity of your vestibular system is in association with your symptoms. So we also, after all of that baseline objective testing, we do a host of neurological, orthopedic, postural, and musculoskeletal tests. You are in with a doctor for multiple hours, and they're checking to see what those systems are doing and how they're functioning together. So do you have a neurological finding that also correlates with the things that we're seeing on your eye exam? Do you have a orthopedic finding that correlates to how that soft tissue is doing, which correlates to how the brain's firing those muscles? One thing that we really, I believe, do a great job of is looking at the system as a whole. And unfortunately, one thing that I think that's happened in medicine, and due to time constraints and just a host of other things, is we've segmentalized so much where we don't look at the fact that organ dysfunction can come from autonomic dysfunction, or we don't look at the fact that a shoulder issue can come from a back issue, or vice versa. We don't look at the connectivity of the body, I guess is what I'm trying to say, as a whole. And when you lose the ability to understand that all of the different systems have to work together as one, you also lose the ability to essentially have a whole picture of your patient to be able to affect them in a treatment manner. So that's one thing we do very, very well, is we look and see how do all the different systems affect that person, and what's working not as well and what's working as best as it can be, and what can we use in a treatment approach. One of the things that we get told a lot, or I hear from patients, is that it's some of the most thorough examinations that they've had, and I really, really much value that information from your day one exam. So at the end of your day one exam, you're going to be sitting down with the doctor that's doing your exam and talking about frequency of care and how long of visits and things like that. But one of the things that I really value about what we do in our office is there is no form of protocol-based care. So we don't have a POTS protocol or a orthostatic hypotension protocol. We do everything based off of what your body needs in that moment. And so not only do you get an individualized treatment plan based off of us creating therapies that will activate or downregulate areas of your brain that are most appropriate for your specific situation, but we also are looking at you from moment to moment and, from visit to visit, and changing that in the moment if need be. And so that's one of the big benefits to being in our clinic, is that you're always in with a doctor. There's never any attack or anything like that. And they're sitting and watching how each specific individual therapy is affecting your nervous system. There's a concept that you never see the same nervous system twice. Once you've put the input in, your body has to take it in, use that information, and have an output. And so we're looking to see, does the treatment downregulate your heart rate? Or in cases with bradycardia, is it upregulating your heart rate? What's happening to your facial tone? What's happening to all these different things that we're looking at to see, is this going to be a good outcome for you or not? And then the treatments that are involved in each visit will be created and performed specifically to address that dysfunction. So again, we're looking at it, what's happening for you in that moment. Is today a good day or bad day? Do we need to scale back a little bit more than we thought we were going to need to? Or can we push you a little bit further that day? And it's important to remember that, again, while symptoms can vary, maybe similar, from person to person, the brain regions that are involved can vary for sure. So we get asked a lot, especially on our consults, well, what does a treatment look like? That being so variable is hard to kind of give you a step-by-step, this is what it's going to look like. But what I'm going to try to do is just give you a couple of concepts of some things that we do. It's not going to be comprehensive by any means, but just a couple of concepts of things that we do to affect different brain function. All right, so I'm going to see if this will let me talk over the video because it didn't want to do it before. Here we go. So what we're doing here is a really seemingly simple therapy. This is called gaze stability, and what he's doing is looking at a target on the wall, and then I'm simply turning his head right and left. And this can be done in a bunch of different planes. It can be done horizontally, it can be done vertically, it can be done in different angles to try to activate either parts of the vestibular system or cerebellums, things like that. But what we're looking at here is a really baseline neurological function that your body has to do throughout the day. So we often throughout our day have to have the ability to look at a target and be moving. And people don't realize that when that is dysfunctional, it can cause things like fatigue. You can have different brain areas that are involved depending upon what's specifically happening. So as a practitioner, I'm looking at a lot of different things for him. So I'm looking to see, is your head staying level? Are your muscles activating appropriately? Are your pupils constricting and dilating in an inappropriate way? Are you able to actually fixate or keep your gaze on that target that we're looking at? And then if you slip off the target, what's happening? So I'm looking to see what the eye movement's doing. Is it acting appropriately? Is it not? And oftentimes I have a pulse oximeter on their finger to see, is their heart rate acting appropriately? Are their oxygen levels acting appropriately? And what does that mean to the health of the overall system? And then this next one. So this specific movement is called a pursuit. It's related back into your parietal lobe in your brain. That's a lot of the times an area that's associated in research with your brain's understanding of where your body is in space. And so as we do this therapy, we would do that if it came up on your exam that we felt like that area needed a little bit of help. It's common in dysautonomias, and a lot of times you see people with dysautonomias, they can be a little clumsy or things like that. So we try to help activate those areas of your brain that tell you about where you are in space. This next one is called a saccade. So I have him look at my nose and then look at whatever finger wiggles. And that is related back into your frontal lobe. So if we, during your exam, found that things were not quite functioning as appropriately as we would be wanting them to with your frontal lobe, that is one of the therapy that would commonly be prescribed in our office. So this is a similar example. We don't always just use gaze stability, so I'm going to go ahead and start playing it. Don't always just use gaze stability. Sometimes we use things like the other eye movement therapies. We'll use something called a complex movement that helps activate your cerebellum. Again, it all just depends on what area of dysfunction we found during your exam. But we're doing a gaze stability on this patient and then moving him up on a tilt table to see where his heart rate becomes irregular. Sometimes it's blood pressure, so it's where's the heart rate on this patient because he's got a pulse ox on that we're watching. Other times we'll pop a blood pressure cuff on the patient and see where their blood pressure goes awry. And I typically will take the patient back down a couple of degrees just before the area of dysfunction and then work them through that area of gravity that their system's having a hard time with. So a lot of people with dysautonomia are familiar with tilt table tests. This is just an example of how we use it therapeutically. So a lot of times in medicine, you'll do a tilt table test, but then people don't go back in and teach your system how to appropriately handle gravity. And so what we're doing is putting you in different positions because, believe it or not, even just something as simple as this is a different subset of neurons in my brain than this, right? So seated, clearly different than standing, standing different than lying. And so we work your body through all these different ranges of gravity to help your brain understand how to function appropriately in those different settings. So this is my last treatment example. It's called an interactive metronome. So I'm going to start playing it and we'll talk about it. So this one activates a bunch of different areas of your brain. It's a motor timing task. So the person has a set of headphones on. They're hearing a beat, it's a metronome beat that they hear at exactly the same time every time, right? And then they're matching their movement to try to hit the pad or the sensor at the exact same time as they hear the beat. This actively involves your frontal lobe. It definitely involves your cerebellum with balance. And then the motor timing task itself is how your brain's connecting to your body. And you're getting feedback on the screen. So your brain thrives on feedback, and it needs that feedback to tell it, is it doing well or is it doing not? And then give you the ability to have these feed forward feedback, efferent copy mechanisms, all these different things that allow you to change how you're responding. So for him, when he's seeing the green on the screen, it means he's hitting at the same time as the beat. Yellow and red to the left meant he was going too fast. Yellow and red to the right meant he's going too slow. And it just helps retrain that system to work to fire appropriately. So along with the things that we do in the office, other things that we take into consideration are things like nutrition and hydration, taking electrolytes, anti-inflammatory diet. And if you are a part of the group that has, it's not a joke, but say PTSD from dysautonomia of drink water, take electrolytes, and eat an anti-inflammatory diet. If you've been to practitioners that aren't as well versed, they are times that they will just say, go home, drink water, you'll be fine, right? And so if you're the person that's like, I drank all the water I can drink, taken all the electrolytes I can take, and I've worn the compression pants. That's not what I'm saying. We have a lot of different therapies that we do. This is just something we use in conjunction with that, because realistically, the more hydrated your body is, the better cellularly hydrated your body is, and the less inflamed that it is, the better it's going to work. We have gentle graded exercises once they're appropriate. Clearly at the beginning of care, not always appropriate for everyone, but once we start getting you back into wanting to live a more active lifestyle, if you do, we can work you into exercise as it's appropriate. We work with stress management, so sometimes that's things like breathing techniques, sometimes that's things like helping you with finding another mental health professional that can be that piece of your puzzle. And then, of course, sleep optimization, so things like trying to get the correct hours to be able to help with your circadian rhythms. Collaboration with other healthcare providers is a huge thing that I love that we do here. We don't consider ourselves an end-all be-all, but we do love to be able to be a resource for our patients and the community. So our group at Georgia Chiropractic Neurology Center has a vast amount of knowledge across multiple different doctors here that love to be able to give you the best input to our abilities about different therapies that you might want to do outside of our clinic or things like that. So it's important for everybody to remember that's going through this, that you're not alone in your dysautonomia journey. There are lots and lots of people in the world with it. Some of the best organizations that I know are Dysautonomia International, are standing up to POTS to look for different resources there. And overall, I just want to say a big thank you for listening to this. If you have any questions, or if you are dealing with some of these issues and you are looking for next steps, this is our team down here in the bottom. We absolutely would love to have you in our clinic. We have a number here, an email, and a website. So give us a call, shoot us an email, or check in with our website to give a request for a consult. We'd love to do a free consultation with you to see if we can start to help you regain your life from dysautonomia. Thanks for listening.